Hello and welcome to the topic Sickle Cell Anemia in the module Haematology. By the end of this topic, you should be able to define sickle cell anemia, explain the pathophysiology of sickle cell anemia, outline the causes and classification of sickle cell anemia, describe the clinical manifestations, outline the investigations done for sickle cell anemia, discuss the principles of management, and discuss the complications and prognosis of sickle cell anemia. Let's get started. Let's begin by defining what sickle cell anemia is. Sickle cell disease and its variants are genetic disorders resulting from the presence of a mutated form of hemoglobin known as hemoglobin S. The most common form of sickle cell disease is an autosomal recessive disorder, which is a homozygous HbS disease or sickle cell anemia. Before we dive into the pathophysiology of sickle cell anemia, it is important for us to understand the formation of hemoglobin. The genes directing the strictures of both fetal and adult hemoglobin consist of a linked pair of alpha chain loci located on chromosome 16 and G gamma A gamma delta beta loci complex on chromosome 11. So unfortunately, still very little is known regarding the regulatory mechanisms involved in the switch from fetal to adult hemoglobin production, although it is likely that there are certain specific areas of the gamma delta beta gene complex involved in this control. Abnormalities leading to hemoglobin disorders and thalassemia result from mutations of these loci, which includes single base substitutions, deletions of one or more bases or entire loci, insertions, frame shifts, fusion genes due to abnormal crossing overs, and ill-defined defects leading to abnormal mRNA structures or reduced rate of transcription. Now let's understand the pathophysiology of sickle cell anemia. Essentially, HbS arises from a substitution mutation where thymine substitutes adenine in the 6th codon of the beta chain gene. So basically, the codon goes from GAG to GTG, coding for the amino acid valine instead of glutamate, affecting the formation of resulting protein produced. The resulting hemoglobin will have the physical properties of forming polymers under deoxy conditions, and these hemoglobins will also exhibit changes in solubility and molecular stability. These properties are responsible for the profound clinical expressions of sickling syndromes. Generally, oxygen tension is a factor that causes polymer formation to occur only in the deoxy state. Therefore, in the presence of oxygen, the liquid state prevails. When RBCs containing homozygous HbS are exposed to deoxy conditions, the sickling process begins. After recurrent episodes of sickling, there will be membrane damage and thus the cells are no longer available to resume their biconcave shape upon reoxygenation, and so they become irreversibly sickled cells. A vaso-occlusive crisis is often triggered by infections in which the levels of fibrinogen, fibronectin, and D-dimer would be elevated in these patients. Plasma clotting factors are likely to participate in the microthrombi in the pre-arterioles. Although hematologic changes indicative of sickle cell disease are evident as early as the age of 10 weeks, symptoms would usually not develop until the age of 6 to 12 months due to the high levels of circulating fetal hemoglobin. These physiological changes in the red blood cell result in a disease with a few cardinal signs such as hemolytic anemia, painful vaso-occlusive crisis, microinfarcts causing multiple organ damage including heart, the skeleton, the spleen, and central nervous system. In some patients, there would be skeletal manifestations due to the changes in bone and bone marrow as a result of chronic tissue hypoxia, which is exacerbated by episodic occlusion of the microcirculation by the abnormal sickle cell. The spleen would enlarge in the later part of the first year of life in children with sickle cell disease. Occasionally, the spleen will undergo a sudden, very painful enlargement due to splenic sequestration crisis. This is basically due to the pooling of large numbers of sickled cells. Although the spleen is enlarged, its function would be impaired as evidenced by its failure to take up technetium during nuclear scanning. Over time, autosplenectomy would occur where the spleen becomes fibrotic and eventually shrinks. The non-functional spleen is a major contributor to the immune deficiency that is seen in these patients. One thing to note that is life-threatening bacterial infections are considered a major cause of morbidity and mortality in patients with sickle cell disease. Recurrent vasoocclusion induces splenic infarctions and consequent otosplenectomy, predisposing the patient to severe infections with encapsulated organisms such as Haemophilus influenza and Streptococcus pneumoniae. Moving on to the causes of sickle cell anemia. As we mentioned previously, sickle cell disease is due to mutations of hemoglobin S. Aplastic crises are usually preceded by a few events such as infection with parvovirus B19, folic acid deficiency, and ingestion of bone marrow toxins like phenylbutazone. The sickling process that prompts the vasoocclusive crisis, on the other hand, may be precipitated by multiple factors such as cold weather due to vasospasms, hypoxia, for example, when flying in an unpressurized aircraft, infection, dehydration, especially from exertion, or during warm weather, acidosis, and alcohol intoxication. Sickle cell anemia may be classified according to two components. First, there is sickle cell trait, HBAS, in which there would be a mutation in one allele of the beta chain gene. There also will be no serious clinical consequences as a result of this mutation. Secondly, it might be classified into sickle cell disease, which occurs as a mutation in two alleles of the beta chain gene, or as HBSS. It may occur as a mutation in two different locations. The symptoms of sickle cell disease usually manifest early in childhood, usually for the first 6 months of life. Infants are protected largely by elevated levels of HbF, after which they will show signs and symptoms of sickle cell disease. And let's start by going over the symptoms of sickle cell disease. Firstly, patients may complain of chronic pain, and this is due to the vasoocclusive crisis occurring when the microcirculation is obstructed by sickled red blood cells, leading to ischemic injury to the organ supply. Next, the patient will present with anemic symptoms like pallor, fatigue, and palpitations. And these symptoms are chronic in nature and usually are very well tolerated. Other symptoms include persistent fever in the case of infection, effects on growth and maturation, especially in the sense of growth retardation, delayed sexual maturation, and being underweight. Infants with sickle cell disease may develop hand-foot syndrome, a dactylitis presenting as exquisite pain, and soft tissue swelling on the dorsum of the hands and feet. These syndromes develop suddenly and last for 1 to 2 weeks. There may also be acute chest syndrome, where young children complain of chest pain, fever, cough, and tachypnea, and whereas adults would usually be afebrile and dyspneic with complaints of severe chest pain. Those with aplastic crisis present with fever, malaise, and a mild rash caused by parvovirus B19 infection. In cases where a child presents with right upper quadrant pain, especially associated with fatty food, consider cholecystitis. You need to also consider common bile duct blockage when a child presents with right upper quadrant pain and dramatically elevated conjugated hyperbilirubinemia. There might also be complaints of leg ulcers which are chronic and painful. They result from minor injuries to the area around the malleoli. Healing is delayed and infection becomes established. There may also be central nervous system involvement, where patients will have a stroke, resulting in varying degrees of neurological deficits and convulsion. Lastly, there might be symptoms of priapism, where there is sustained painful and unwanted erection. Moving on to the signs, the patients can display signs of life-threatening infections such as fever, deafness, signs of arthritis, and meningitis. Those in intermittent crisis may be having signs of splenic sequestration, vasoocclusive crisis, and hemolytic crisis. Some patients may even have stroke, as mentioned earlier, which can be quite overt and present with signs like seizures, focal paralysis, and altered consciousness. In addition to that, the patient can also appear to be pale and have jaundice. They may also have signs of heart failure. These are the other signs that can also be manifested, which include dactylitis, leg ulcers, splenomegaly, and proliferative retinopathy. Now let's look into the investigations. Investigations-wise, you should order a few blood investigations such as full blood count, where the hemoglobin levels are usually 6 to 8 grams per deciliter, and a peripheral blood film in which you would expect to see sickle cells, target cells, and whole jolly bodies. You may also consider a sickle dex test, which is a specific test used to identify sickle cells as HBS blood with sickle cell. In the case of screening newborns for sickle cell disease at birth, a Guthrie test can be done where a positive test indicates sickle cell disease. And lastly, it is crucial to do a prenatal screening, This can be done by molecular testing of chronic villus sampling at 8 to 10 weeks gestation. A hemoglobin electrophoresis or isoelectric focusing on high-performance liquid chromatography can be done to detect the relative quantities of HbS, HbF, and Hba. The National Institutes of Health advises that optimal care for those with sickle cell disease as well as preventive care is best established through treatments in clinics specializing in these sort of diseases. So all patients with sickle cell disease should have a principal healthcare provider who's either a hematologist or someone who will be in frequent consultation with one. Generally, the goal of treatment would be symptomatic control as well as management of any complications. Treatment strategies are said to follow 7 main goals, which include the management of vaso-occlusive crisis, chronic pain syndromes, chronic hemolytic anemia, prevention and treatment of infections, management of the complications and the various organ damage syndromes associated with the disease. For those in sickle cell crisis, when the severity of the episode is accessible, self-treatment at home with hydration and oral analgesia and bed rest is sufficient. However, if self-treatment fails, then the patient should present to the emergency department. General treatment would include administration of folic acid or oral penicillin daily due to otosplenectomy. It is also important to advise the patient to avoid any precipitating factors as mentioned previously and to ensure to be triple vaccinated against pneumococcal, Haemophilus influenza, and meningococcal, as well as to get regular influenza vaccination. If the patient is in crisis, the first step is to stabilize the patient, admit the patient to the hospital, look at their full blood count, a peripheral blood smear, reticulocytes, liver function tests, a CRP level, as well as x-rays if there are any respiratory symptoms or signs. ECG is done if they're experiencing any chest pain, and a midstream urine and blood cultures if infections are suspected. You may also need to administer strong analgesia, fluids, oxygen, and ensure that the patient is kept warm with proper bed rest. In addition to that, you would need to monitor their vital signs closely, administer intravenous antibiotics, and carry out any transfusions or exchange transfusions if necessary. Whenever a major surgery is indicated in patients with sickle cell disease, transfusions need to be performed pre-operatively in order to reduce the HbS fraction to less than 30%. Anesthetics play a vital role in making sure that the patients are kept warm, well oxygenated, hydrated, pain-free, and any state of acidosis is avoided. Besides that, bone marrow transplant or even stem cell transplant is indicated in severe cases of the disease. There are a few complications associated with sickle cell disease. Firstly, there are sickling crises that last approximately between 5 to 7 days. Then we have hemolysis crisis, where there would be an acute accelerated decrease in hemoglobin levels due to the fact that the red blood cells break down at a faster rate. This condition is commonly seen in patients with coexisting G6PD deficiency, and you will need to manage this crisis supportively. In some cases, blood transfusions may be needed. Next, there is splenic sequestration crisis, and this is a life-threatening complication which is hyperacute low hemoglobin due to splenic pooling of RBCs and sickling within the spleen, leading to moderate to massive splenomegaly. As a result, the patient's respiratory rate increases and there will be hypovolemic shock. There will also be an increased risk of infections from encapsulated organisms, and this may be transient or continue for 3 to 4 hours and maybe last for 1 day. Management-wise, you would want to do a blood transfusion, provide the patient with prophylactic antibiotics and vaccination. Moving on, we have aplastic crisis. This is when an acute reversible worsening of the patient's baseline anemia, which is usually triggered by parvovirus B19 infection, is seen. And this virus will invade the RBC precursors. They multiply and they destroy the RBCs, leading to an almost complete cessation of red blood cell production for 2 to 3 days, causing reticulocytopenia. There will be rapid red blood cell turnover but low hemoglobin levels, and they would usually present with pallor, tachycardia, and fatigue. You will manage this supportively, and in some cases, blood transfusions might be needed. Another complication would be vaso-occlusive crisis, and this may occur in any organ, and the patient may present with symptoms of pain or organ dysfunction due to restricted blood flow causing ischemia, leading to pain and necrosis. Acute chest syndrome may be seen when there is vaso-occlusive crisis with lungs being evident of new infiltrates on chest X-ray. It is defined by the presence of two or more of the following, which includes chest pain, having fever, pulmonary infiltrates on the chest X-ray, or focal abnormality seen. And the second most common complication seen in sickle cell disease, accounting for 25% of deaths, is acute chest syndrome. The management would include early recognition and prevention of arterial hypoxemia, providing enough oxygen and fluids, analgesics as necessary, antibiotics if there's any suspected infections, bronchodilator therapy, red blood cell transfusions are given, and rarely this is an exchange transfusion, as well as incentive spirometry to assist with the reduction of the atelectasis that has set in due to the acute chest pain. Next would be pain crisis. Pain crisis, on the other hand, is the most common type of vaso-occlusive event, and there would be microvascular painful infarcts, commonly seen in the muscles, bone marrow, lungs, and intestines, usually localizing to the long bones of the arms or legs, but can also occur in smaller bones. This usually lasts for 2 to 7 days. The crisis within the femur would cause avascular necrosis of the femoral head or chronic hip disease. The management would include fluids, analgesics, usually narcotics, and NSAIDs, oxygen if hypoxic. Priapism can occur in boys, and these boys will experience sudden painful onset of erection that will not relax. In this scenario, you would provide them oxygen, fluids due to renal medullary infarction, which results in loss of ability to concentrate the urine, analgesics, and transfusion to achieve the HBS, often by partial exchange transfusion. Now let's look at the prognosis of this condition. Due to the fact that sickle cell disease is a lifelong disease and its prognosis is guarded, the goal is generally to achieve a normal lifespan with minimal morbidity. Vaso-occlusive crisis and chronic pain are associated with considerable disability. Repeated infarctions of the joints, bones, and growth plates could lead to aseptic necrosis, especially in weight-bearing areas such as the femur. And this complication is associated with chronic pain. Vaso-occlusive crisis and chronic pain are associated with disability, as mentioned earlier. There are a few poor prognostic factors, which include hand-foot syndrome, dactylitis in infants younger than 1 year, HB less than 7 grams per deciliter, and leukocytosis in the absence of an infection. It was found that hand-foot syndrome affecting children younger than 5 years have proved a strong predictor of overall severity such as death, the risk of stroke, high pain rate, and recurrent acute chest pain. Now let's summarize what we have covered so far. The most common form of sickle cell disease is homozygous HBS disease or sickle cell anemia, which is an autosomal recessive disorder. HBS arises from a mutation substituting thymine for adenine in the 6 codon of the beta chain gene. Clinical manifestations of sickle cell disease include anemic features, chronic pain, fever, and specific features of sickling crisis. Investigation-wise, it is crucial to order blood investigations, sickle dex tests, HB electrophoresis, isoelectric focusing, high-performance liquid chromatography, Guthrie test, and to do a prenatal screening. And when it comes to treatment, the main goal is to provide symptomatic control and management of the disease complications. We have come to the end of this topic. Thank you.